So now we will move on to the next talk, a very interesting one by Dr. Jody Duche. And she is going to talk to us about pharmacological therapy for obesity management. Have we got the holy grail? So, Dr. Duche's clinical research focuses on obesity and its complications. She leads several human clinical research studies in the area of human obesity and metabolic disease, and also maintains a clinical practice in adult endocrinology. Her research focuses on mechanisms of weight loss through activation of GLP1 and on the physiology and regulation of the hormone fibroblast growth factor 2 1 in humans. In addition to her clinical research and clinical practice, Dr. Duche serves as the medical director for the Harvard Catalyst Clinical Research Center and as vice chair on the Institutional Review Board of the Beth Israel Deaconess Medical Center. Dr. Duche is a member of several professional societies, including the Obesity Society, the ADA, and the ACE. We're very proud to have Dr. Jody Duche. I hand over the mic to her.
Okay, excellent. All right, so have we found the Holy Grail? Yes and no. I won't get straight to the punchline, but hopefully my talk will be will include some of the topics that have come up before, but this is going to focus primarily on the pharmacologic management of obesity. Have we found the Holy Grail? All right, in the next half an hour, I'm going to start by giving a brief overview of the physiology and regulation of food intake. I think it's important to go over this as a framework for understanding how pharmacotherapy works for the treatment of obesity. Then I'll just touch on the guidelines for the medical treatment of obesity, and then dive into pharmacotherapy for weight loss. What's available, what are the side effects, and how do we decide which agent to choose? I'm going to go through a clinical case, which I think is always a practical way to think about these medications. I have no disclosures to declare. All right, so let's ask the question, what regulates why and how we eat? Specifically, what regulates our appetite, our food choices, when we eat, how much we eat, and when we stop eating? All right, so there are two primary drives to eat. One is called the homeostatic or the metabolic drive to eat. And typically that is going to drive us towards a food that is a very high nutritional quality. So for example, this piece of fish with some avocado and tomatoes, we get hunger signals both centrally from the brain and peripherally from the gut, the stomach, and the intestines that talk to the brain. So there's a lot of crosstalk to inform for those organs to inform each other what is the state of energy stores in our body. We then seek a food source. At that point, hormone signals from the GI system sense that calories are coming in. There's work to do to process them and get the nutrients and then store the extra energy. And so the GI system talks back to the brain, energy stores are increased. Brain then releases some satiety signals. These are neurotransmitters, primarily from the arcuate nucleus of the hypothalamus. And then we stop eating. So it's a very elegant and tightly regulated network. There are, of course, a lot of redundancies because we need to eat in order to survive evolutionarily. But this is sort of this very clean loop, the homeostatic or the metabolic drive to eat. However, there's another drive to eat, equally real, equally important for a happy and healthy life, and that is the hedonic or the pleasure drive to eat. Now, we may or may not actually have a true metabolic hunger signal from the brain or the periphery saying that energy stores are low. However, we want to take part in a pleasurable activity. Perhaps we're celebrating something, and so we want to indulge in a certain kind of food. Other times, maybe we have had a stressful situation, and we want to engage in eating behavior to sort of help us get over that. So we're looking for something pleasurable as kind of an antidote to another stress. So there might be a food source right in front of us that we see or smell, or we might think of something that we want to eat, maybe more as like a craving. And then the eating that we do when we have this drive to eat is reinforced by other neuropeptides. It's really a totally different brain network with different hormones that are secreted, different neuropeptides. And it's different from this homeostatic drive to eat. Other times we may actually frankly ignore satiety signals. Say we're at a wedding and we've had a really enjoyable evening. There's been a lot of food for many hours, and then it's time to have the wedding cake. We might be full, but we want to partake fully in this event. And so we say, yeah, I know I'm full, but right now I still want to take part in this. I still want to have the wedding cake. And so there are indications or there are situations when we might ignore these satiety signals. And so this hedonic drive to eat is different. Again, both are regulated in the brain, and both are part of a normal eating behaviors. However, when we think about pharmacotherapy, we want to remember that many of them do act through appetite centers in the brain. As we know, it is difficult to lose weight, and it is especially difficult to maintain weight loss. Really, I think that maintenance of weight loss is, in fact, a much harder for most people. Metabolic changes do not favor weight loss, and in particular, they don't favor maintenance of weight loss. Weight loss is usually associated with a decrease in total energy expenditure, a resting metabolic rate, which is out of proportion to changes in lean body mass. So the number of pounds that we see lost on the scale can be separate, can disassociate from how much our resting energy expenditure changes when we lose weight. This is a normal physiologic adaptation to decreased energy intake and decreased body weight. This persists as long as the reduced weight is maintained. So basically, when there is negative energy balance, your body says, maybe there's a threat to survival. And so certain metabolic adaptations take place, such as decreasing the resting metabolic rate. If the caloric restriction is very severe and very prolonged, then other hormonal axes also are shut down or are dampened in order to preserve energy. And again, these do persist. There are increased hunger and decreased satiety signals that occur after weight loss and that persist after weight loss. So there is increased secretion of these hunger hormones that can originate, again, in the gut or even in the brain. And there's an increased subjective perception of hunger. There's also decreased secretion of satiety hormones and a decreased perception of fullness. And again, this persists. So I find that knowing this is helpful for counseling patients right from the beginning. I mean, certainly you don't tell patients, you don't say to someone, well, if you think it's hard to lose weight, just wait until you see how hard it is to maintain weight loss. Of course, you wouldn't say that, but it's helpful to help people understand that it is normal to have plateaus. It is normal to have weight fluctuation, and it's difficult to maintain weight loss. And often it's going to be associated with a sense of hunger and getting people to understand that where they fit in that scale of hunger and what is tolerable is really important, especially for the maintenance of weight loss. So let's now go into a clinical case. This is, I think, will be familiar to probably, hopefully, everyone listening. A 53-year-old female, type 2 diabetes, taking metformin monotherapy, 1,000 milligrams twice a day, A1C 8.3%. She also has hypertension treated with 2 agents, ACE inhibitor lisinopril 20 milligrams daily and a calcium channel blocker amlodipine 5 milligrams daily. She has GERD, which is mild and doesn't require taking a proton pump inhibitor. She has depression, for which she takes an SSRI, a remote history of a seizure disorder, gallstones, and she has not had a cholecystectomy, and she went through menopause at age 51. All right, so I typically, when I see patients as a new consultation, I do an obesity-focused history. So first going through life events and weight gain to try to understand the what her weight has been over her lifespan. And in particular, have there been any events that have caused a quick uptick in weight? Did she stop smoking? Was there a medication that was introduced? Did she gain a lot of weight when she started taking the antidepressant? How much weight was gained in pregnancies? How much weight was lost postpartum? Was there weight gain after menopause? Were there any major life stressors? And was there any major change in lifestyle, such as some sort of a major surgery that required a period of being sedentary in an otherwise very active individual? Of course, taking a diet and activity history is important. What is the extent of their current daily physical activity? What are sleep habits, any sleep difficulties? Food preferences and frequency and quantity of meals. Is this someone that eats 3 meals a day, does a lot of grazing, snacking, intermittent fasting? Find out what they're currently doing or what they've tried. And then a psychological assessment. Again, I'm not a psychiatrist or a psychologist, but just do they have a history of being treated for mood or anxiety disorders, ADD, PTSD, and importantly, any history of eating disorders as well. Sometimes behaviors that you might want to encourage someone to do, like careful food logging, could be a trigger in someone who's had an eating disorder. So you want to know that upfront. Doing a review system, going through especially any obesity specific related complications, such as type 2 diabetes, fatty liver disease, sleep apnea, hypertension, hyperlipidemia, and weight loss readiness. What is the degree of motivation and social support at this time? Psychiatric status, presence of stressful life circumstances at this time, any time constraints, and what are the goals and expectations for weight loss? All right, getting back to the case. So this woman reports that she's had gradual steady weight gain over the past 10 to 12 years, about 5 pounds per year. She gained 15 pounds during the COVID pandemic due to being much more sedentary, more stress eating. She has had 2 pregnancies and delivered 2 children. First pregnancy, she gained 30 pounds, lost just a little bit of that afterwards. And second pregnancy, gained 35 pounds. Again, she did not have full weight loss following that. She's lost about 5 pounds over the past 2 months with a change in diet and a bit more exercise. Her appetite is robust. She endorses having some cravings and having large portions. She has tried Weight Watchers. She lost about 10 pounds, but regained when she stopped attending that. Her current diet, she tries to limit refined sugar. She eats a lot of protein and healthy fats. She's thinking about starting a ketogenic diet, a very low carbohydrate diet, or maybe intermittent fasting, but she hasn't started either. In terms of exercise, she does water aerobics twice a week, and she works with a trainer also once a week. On exam, she is hypertensive with blood pressure 156/90, heart rate 75. This is, remember, on 2 blood pressure agents. Her height is 67 inches, weight 266 for a BMI of 41.7. So that's going to be class 3 obesity. She does have acanthosis on exam. She does have a small cervicodorsal fat pad. There is central distribution of body fat, much more around the abdomen compared to the extremities, the thigh and buttock areas. No wide purple striae on her abdomen, and she has 1+ edema on her lower extremities. She's very interested in medication for weight loss. All right, so what are the guidelines for using pharmacotherapy for weight loss? Well, there is, the guidelines currently say that medications can be used as an adjunct to diet and exercise in patients with a BMI greater than or equal to 30 or greater than or equal to 27 with 1 or more weight-related comorbidities. Now, the guidelines include the following comorbidities: hypertension, type 2 diabetes, hyperlipidemia, sleep apnea. They don't specifically include depression, osteoarthritis, or fatty liver disease. So, as a physician, you have to take into account maybe if someone does have, say, very severe depression or have fatty liver disease or very, very severe arthritis, and the BMI is, say, 28. Would you consider this person for pharmacotherapy? And certainly guidelines are meant to be just that, guidelines. And so you want to individualize your care of every patient. You should then assess efficacy of the medication that you're choosing at 12 weeks' time. The currently available drugs for the treatment of obesity in the US are orlistat, phentermine which at higher doses is for short-term use only, 6 months, phentermine plus topiramate in combination, bupropion plus naltrexone in combination, and then liraglutide and semaglutide. Lorcaserin was withdrawn from the market in the US in February of 2020. Orlistat is a lipase inhibitor which reduces fat absorption. You need to avoid this medication if someone has a history of oxalate nephrolithiasis, cholestasis, or chronic malabsorption. People must follow a low-fat diet when they take this medication, and the side effects are typically pretty common and unpleasant. That's not a good option for this patient because weight loss is typically modest. Side effects are unpleasant, and it really doesn't suppress appetite. And she's endorsing that she has cravings and has a pretty robust appetite. So I wouldn't use orlistat as a first choice in this patient. She also has a history of gallstones, which would make this not a good choice. The adverse effects are fecal urgency and increased frequency, stool leakage or incontinence, oily stool, and flatulence. And again, these do occur pretty commonly. Another option would be phentermine with or without topiramate. So phentermine is a sympathomimetic, and topiramate is a GABAergic agent. These two medications have a synergistic effect on appetite suppression. Weight loss in clinical studies and large clinical studies show about 8 to 10% body weight. It is higher with higher doses of phentermine monotherapy. However, as I mentioned earlier, you can only use high-dose phentermine for 6 months due to cardiovascular side effects, including cardiomyopathy and increased hypertension. So this wouldn't be a good option for this patient because she already has uncontrolled hypertension. Here's just one of the, here's a slide that's showing two of the large studies, the Conquer trial and this sequel extension study that is looking at the combination phentermine and topiramate packaged together as Qsymia. That is the name brand. However, they can be prescribed independently, both as generics, showing about 12% weight loss, maybe a little bit of regain you can see in the as the extension trial continues. And this is looking at placebo versus 2 different doses of phentermine and topiramate. The intermediate dose of 7.5 milligrams of phentermine with 46 of topiramate, and then the highest dose it goes up to, which is 15 milligrams of phentermine and 92 milligrams of topiramate. As I said, this is in the name brand Qsymia. However, these medications can also be prescribed separately, independently, and you can approximate the dosing if you do that. And the advantage to that is that you can also, depending upon tolerance, you could maybe increase the dose of topiramate and not phentermine, or vice versa, depending upon what side effects someone might be experiencing. The most common side effects of these 2 agents, so phentermine can cause palpitations, diaphoresis, increased blood pressure, tachycardia, dry mouth, constipation, or feeling jittery or anxious. Topiramate can cause brain fog, scalp hair thinning, visual change, metallic taste, paresthesias in fingers and toes, nausea, and very importantly, this is category X. So women of childbearing potential have to be using a reliable form of contraception, such as the pill or an IUD. Condoms alone are not sufficient. So that's something that is very important to keep in mind. Another option to consider is bupropion and naltrexone. These are also come together in a pill that's the name brand is Contrave, but can be prescribed as well independently as both bupropion and naltrexone, just as the generics. These work through POMC neurons in the hypothalamus to increase the release of alpha MSH, which is anorectic, and then naltrexone potentiates the bupropion so that you have synergy as you have with the phentermine plus topiramate. This can help with cravings and to improve satiety. It can also help with depression. Not a good choice for this patient, however, because bupropion can lower the seizure threshold, and our patient does have a remote history of seizures. She also has uncontrolled hypertension. So again, this wouldn't be a great choice. This is looking at weight loss with this combination. Specifically, this is with Contrave, looking at 2 different doses of naltrexone plus bupropion compared to placebo, showing about 8% weight loss from compared to baseline at the highest dose, which is 32 milligrams of naltrexone plus bupropion, and at the lower dose, it is the weight loss is a little bit less. The adverse effects include nausea, constipation, increased blood pressure, change in mood, headache, and vomiting. And now the GLP-1 receptor agonists. These have gotten a lot of attention recently. GLP-1 has a lot of actions throughout the body that contribute to both its efficacy as well as some of the adverse effects. So at the level of the looking at efficacy first, GLP-1 agents increase insulin biosynthesis, increase beta cell proliferation, and decrease beta cell apoptosis. This is primarily has an effect, obviously, on glycemia. At the level of the brain, there is some evidence there is some neuroprotection against certain disorders that impair cognition, and it also works to reduce appetite. So there are GLP-1 receptors in the brain, and so there is a central effect on appetite reduction. Also, there is a peripheral effect by delaying gastric emptying. Food staying in the stomach longer causes stretch receptors to be activated, as well as other hormones to be secreted, which inform the brain that there is increased energy in the intestines, and so the satiety signals are prolonged, and so you are increasing your sense of fullness for longer. At the level of the liver, there is increased insulin sensitivity and decreased glucose production. Also, this primarily affects glycemia, but also can help with insulin resistance. The adverse effects, however, are related to these actions in the periphery. So there is increased nausea and vomiting, primarily due to delayed gastric emptying. You can also get constipation more commonly than diarrhea, but people do report both. There can be some mild tachycardia due to GLP-1 receptors in the heart, and there is an increased risk of pancreatitis as well. So liraglutide reduces appetite through delayed gastric emptying and central GLP-1 receptors. It is taken daily by subcutaneous injection. The type 2 diabetes dosing is 0.6, 1.2, or 1.8 milligrams, and the dosing for weight loss is 1.8, 2.4, or 3.0 milligrams as Saxenda. This would be a good option for this patient, a GLP-1 agent, because she doesn't have any history of pancreatitis. She doesn't have any personal or family history of medullary thyroid carcinoma. I'll talk about the contraindications for using these medications in a moment, but this would be a good option given her other medical conditions. This is a slide showing weight loss with liraglutide at the 3.0 milligram dosing. That's the highest dosing for weight loss, showing both on treatment and off treatment, extending for up to 3 years. So what we're seeing is about 9.2% is the most weight loss. There is over time a little bit of regain, and then off treatment there is more regain. It's not the same rebound that you see following, say, high dose phentermine, where there is a weight rebound that is really almost always back to baseline. And this is compared to placebo. In this study, there was about 2%, 2 to 3% weight loss. Semaglutide is the other GLP-1 agent that is approved for weight loss. Recently approved in the US under the trade name Wegovy. So these are weekly injections. The type 2 diabetes dosing is 0.25 to 1 milligram once per week. The dosing of Wegovy, or for weight loss, is 0.25 going up to 2.4 milligrams, although some of the clinical studies did go up to 3 milligrams of this medication. There is also an oral option for type 2 diabetes that is 3, 7, or 14 milligram pill that is taken once daily. Semaglutide would also be a good option for this patient. The GLP-1 agent adverse effects, as I mentioned before, with that other cartoon, you can have nausea, vomiting, increased GERD, headache, constipation, diarrhea, pancreatitis. You should avoid this class of medications if a patient has a personal history of pancreatitis. And as well, there are GLP-1 receptors in the rat thyroid, and there has been noted to be an increase in medullary thyroid carcinoma in rats. So these medications should be avoided. There's a black box warning to avoid them in people with a personal or family history of medullary thyroid carcinoma or MEN2 syndrome. This is just a comparison of the semaglutide trials. They're called the STEP trials, and they have been, these STEP trials were done in people with and without diabetes. So the first trial is done in obesity without diabetes. The second one is with type 2 diabetes. The third one is intensive behavioral therapy, no diabetes. And then the fourth one is looking at sustained weight management. There was a run-in period of weight loss with a very low calorie diet, and then looking at adding semaglutide to that. But the point of this slide is really to show that compared to the other slides I showed, weight loss is definitely more robust with this agent. So on average, in these studies, really about 15 to, in the STEP 4 study, 17.4% weight loss on average with weekly semaglutide compared to placebo. This is showing the some of the studies had two different doses of semaglutide, 1 milligram versus the 2.4 milligrams. But in the other studies, when you're comparing the 2.4 to placebo, you see that the weight loss really is quite robust. So this, I just wanted to put together really all the agents that I've mentioned. So this is weight loss across clinical trials. These are not head-to-head trials. What I've done in this slide is I've summarized weight loss in pharmacotherapy clinical trials, as well as two other studies, the diabetes prevention program, which looked at both metformin and lifestyle intervention for the prevention of the development of type 2 diabetes. And then the Look Ahead study, which is a purely behavioral, very intense behavioral intervention study. And then we've got, in comparison, the large clinical trials. I just selected for each agent, one of the large clinical trials. And so this is showing the green bars are 5% weight loss, the red bars are 10%, and the blue bars are 15%. It's important to note, though, that the 5% includes those who lost 10 and 15%. So if it says more than 5%, remember that those numbers are folded into that. That's why you're seeing these numbers into the 80%. And then the percentage of patients who lost 10% includes also those who lost more than 15%. So you see that the GLP-1 agents do have much higher numbers of people, in particular, losing 10 and 15% weight loss. So the more robust weight loss is happening with these GLP-1 agents compared to, for sure, compared to some of the others like orlistat, as well as even naltrexone, bupropion, and then phentermine and topiramate. However, I do want to point out that despite the fact that you're seeing here that roughly, say, 83% of people treated with 2.4 milligrams of semaglutide once a week lost at least 5% of their body weight, which is what the guidelines say is the what you should use to determine efficacy. If people have not lost 5% after 3 months, then you would stop that agent and try something else. However, it's 87%. 13% of people did not lose at least 5% body weight. So there are really also non-responders to these agents. So you don't know until you try an agent how any individual is going to respond. But people do, I do have patients coming to me saying, you know, I've seen articles in the lay press, I've seen medical articles, I really, really want this agent, and then being maybe very disappointed if they don't have any weight loss. But remember that 13% of people didn't lose at least 5% of their weight. And if you, not all of these studies show the data that is parsed out among the non-responders, but within those people, there are people who lost, really had no weight loss at all, maybe even a little bit of weight gain up to, you know, losing just under 5%. But just keep that in mind, that there is tremendous heterogeneity in terms of weight loss response. Early weight loss does often predict long-term weight loss. So in my experience, if people, although you should determine efficacy at 3 months, typically if people have tolerated a medication and you've titrated the dose up to the maximum dose, and there hasn't been any weight loss after 2 months, in general, you're not going to see that, all of a sudden the drug sort of kicks in and you get a lot of efficacy. Typically, if you're not seeing any change at all after 2 months, probably that agent isn't going to work. And so early weight loss as a predictor of long-term weight loss, I think also helps people to understand that you'll try something and then you won't see them back in 6 months' time. Really, you'll know in a month or two whether or not this is what you're going to stick with or you're going to try something else. Remember, there is also heterogeneity of response to dietary interventions. And I just point this out because, again, here is typically studies don't show this, all of these curves. Typically, a study will show just this average line. So you say low carbohydrate ketogenic diet compared to orlistat plus a low fat diet. So here what you're seeing is on average, people are losing, say, close to 10% weight loss, maybe with a little bit of regain over time, compared to orlistat, where, again, you're seeing similar weight loss. But look at this heterogeneity of response. Some people on a ketogenic diet are actually gaining weight or having very modest weight loss. And also there are some real super responders who are losing 20 or even 25% of their weight, similarly with orlistat plus this low-fat diet. So again, really important to keep in mind heterogeneity of response to pharmacotherapy and dietary interventions. And that's why being in close touch, providing ongoing support and encouragement, and really being flexible with what is and is not working with patients is very important for the treatment of obesity. So in summary, many factors control appetite and food intake. There are redundant systems to protect our body weight and to keep our body fat level at a certain set point. Obesity is a chronic disease that results from dysregulation of energy homeostasis. There is an abnormally high set point of body weight, which really we don't understand why that occurs. Attention to lifestyle is a cornerstone of obesity treatment for sure, but there is a role for pharmacotherapy to treat obesity. And you just need to consider the risk benefits as well as patient preference when you are considering pharmacotherapy. So have we found the Holy Grail? I think the Holy Grail is of course, a combination of very, very high quality diet, regular exercise, regular meaning daily, and ideally getting up to an hour a day. And in many cases, depending upon patient preference and BMI, the addition of pharmacotherapy that is tailored to the individual patient. So thank you very much for your attention and time. And I look forward to answering some questions in the panel.
Thank you so much, Dr. Jody, for that very illuminating